Somewhere between panic and denial, almost everyone eventually stands in the shower staring at the drain wondering the same thing. Is this normal? Or is something actually wrong? Turns out there's a real, specific answer. Here's a myth worth killing immediately. Finding hair on your pillow or in your brush means something is wrong. It usually doesn't. Every hair on your head is on its own private timer, and losing some every day is simply how the system is built to work. The actual number most dermatologists cite: somewhere between 50 and 100 hairs shed per day, out of roughly 100,000 hairs on an average scalp. That's a tiny, constantly replaced fraction, not a sign of decline. But hair loss as a medical issue is genuinely common too. Up to 80% of men and roughly half of women will experience some degree of pattern hair loss in their lifetime. This isn't a niche problem. It's one of the most common reasons people see a dermatologist at all. So what actually separates normal shedding from a real problem? 3 things. A noticeable overall change in density over weeks or months, visible thinning in a specific pattern rather than even all over, or distinct bald patches appearing suddenly. To understand any of those 3 signals properly, you first have to understand something most people never learn. Hair isn't just growing constantly. Each strand cycles through distinct phases, and that cycle is the key to understanding everything that can go wrong. One flag worth taking seriously right away, before anything else in this video: sudden, patchy, well-defined bald spots, especially appearing over days rather than months, deserve a doctor's visit sooner rather than later, not a wait-and-see approach. So keep that distinction in mind as we go. Shedding is normal biology. Pattern, sudden onset, and real density change are the actual signals worth paying attention to. So let's actually open up the system. Every hair on your head grows out of its own tiny, self-contained organ buried in your skin, and understanding that organ explains nearly every hair loss condition that exists. That organ is called the hair follicle. It's a small pocket of skin containing a root, a blood supply, and a cluster of active cells at the base that continuously divide to push new hair upward. Essentially a tiny, self-sustaining hair factory. Here's what that factory actually looks like on the inside: the root sitting deep in the skin, the blood vessels feeding it nutrients, and the layered structure that builds each strand of hair from the inside out. That factory runs on a cycle with 3 phases. Anagen is active growth lasting years. Catagen is a brief transition where growth stops. Telogen is a resting phase, after which the old hair sheds and the follicle starts the whole cycle over from scratch. The growth phase alone typically lasts 2 to 7 years per hair. Exactly why hair has a natural maximum length before it sheds and restarts, while the resting phase before shedding is much shorter, usually around 3 months. This is exactly why the cycle matters for hair loss. Some conditions just shorten how long the resting phase lasts, which is temporary and reversible. Others actually shrink the follicle itself each cycle, which, left long enough, stops producing a visible hair at all. Keep that follicle factory in mind for the rest of this video, because every cause of hair loss we're about to cover comes down to one question: is it disrupting the cycle temporarily, or shrinking the factory itself? By far the most common cause of hair loss on the planet has a specific name, a specific hormone, and a specific mechanism, and once you understand it, half the internet's hair loss confusion disappears. In genetically susceptible follicles, testosterone converts into a more potent hormone called DHT. DHT binds to receptors in the follicle and, over repeated cycles, gradually shrinks it, producing progressively finer, shorter hairs until the follicle eventually stops producing a visible hair at all. In men, that shrinking follows a famously predictable map, first charted in the 1950s and known as the Norwood scale, a receding hairline and thinning crown that progresses through recognizable stages, letting doctors describe severity in one shared language. The pattern itself looks genuinely different by sex. In men, it's a receding hairline plus a thinning crown that can eventually merge into full baldness on top. In women, it's usually diffuse thinning across the crown, with the frontal hairline typically staying intact. By the numbers, roughly 16% of men in their 20s already show at least moderate pattern loss, and by their 40s that climbs past half. Genetically susceptible men, it's genuinely a matter of when, not if. Over years, watch what actually happens to a single follicle. Normal, thick, pigmented hair gradually becomes shorter, finer, and lighter with each cycle, until eventually it produces only a wisp of colorless fuzz, and then nothing visible at all. One genetics myth deserves retiring here. Baldness comes from your mother's side only. It's actually influenced by genes from both parents. The maternal side gene just happens to carry unusually strong influence, not the whole story. So here's the honest takeaway on pattern loss. It's genetic, it's hormonal, it's progressive if untreated, and it's also the single most treatable and predictable form of hair loss that exists, which matters enormously for everything coming up in this video. So one hormone, one genetic predisposition, one predictable map, that's pattern hair loss, and it accounts for the overwhelming majority of hair loss cases you'll ever encounter. Pattern loss is the majority, but it isn't the whole story. A handful of other genuinely distinct medical causes exist, and telling them apart correctly changes the entire treatment plan. Split hair loss into two broad families first. Non-scarring, where the follicle survives and regrowth stays possible, and scarring, where the follicle is permanently destroyed and replaced with scar tissue. That single distinction shapes everything a doctor does next. The most common non-pattern cause is telogen effluvium, a stress response where a major physical or emotional shock pushes an unusually large share of follicles into the resting phase all at once, causing a dramatic, diffuse shed roughly 2 to 3 months later. The classic triggers are worth knowing by name, because recognizing one often explains a scary shed instantly. Childbirth, a high fever or major illness, sudden extreme weight loss, major surgery, or a period of intense emotional stress. A completely different mechanism drives alopecia areata. This is autoimmune, meaning your own immune system mistakenly attacks healthy hair follicles, producing sudden, smooth, well-defined bald patches like the one shown here. The numbers here need careful framing. At any given moment, only about 2% of people have active alopecia areata. But recent research on lifetime risk, ever developing it even briefly, puts that figure far higher. Nearly 1 in 3 women and roughly 1 in 6 men across their lifetime. Line all three up and the differences become obvious. Pattern loss is gradual and follows a genetic map. Telogen effluvium is diffuse and follows a stressful trigger by weeks. And alopecia areata is sudden, patchy, and autoimmune. A few other medical contributors are worth screening for too because they're often correctable. An underactive thyroid, low iron stores even without full-blown anemia, a recent crash diet lacking protein, and certain medications including some blood thinners and blood pressure drugs. So before assuming any hair loss is just genetics, it's worth ruling these other causes out first. Several of them are entirely reversible once the actual trigger is identified and addressed. With that many possible causes, the natural next question is simple. How does a doctor actually figure out which one is happening to you? The process is more straightforward and less invasive than most people expect. Quick pause. If this breakdown is helping you, take a second to hit like and subscribe. It genuinely takes a lot of effort to make videos like this, and your support keeps them coming. A dermatologist's toolkit starts simple. A gentle pull test, tugging a small group of hairs to see how many release, followed by dermoscopy, a handheld magnifying tool that examines individual follicles and hair shafts up close for telltale patterns. A blood panel usually follows if the picture isn't obvious. Thyroid function, iron stores via ferritin, and sometimes vitamin D or zinc levels, all cheap, standard tests that catch the correctable causes we just covered. So a real visit typically flows like this: history and pattern assessment, a pull test, dermoscopy, blood work if indicated, and a clear plan, often on the very same day without needing a biopsy at all. Here's a simple self-check to work through before you even book that appointment. Gradual and pattern points toward genetics, diffuse and recent points toward a stress trigger, and sudden round patches point toward an autoimmune cause, any of which is worth a professional opinion. One more red flag worth flagging clearly: hair loss paired with scalp pain, itching, redness, or visible scarring should never wait for a routine slot. That combination can signal an active inflammatory process damaging follicles permanently right now. The bottom line on diagnosis: it's fast, it's mostly painless, and getting the right label early is what makes every treatment decision that follows actually work. Now for the part everyone's actually here for: what genuinely works, backed by real evidence versus what's mostly marketing. 3 treatments have decades of real data behind them. Minoxidil, applied directly to the scalp, works by widening blood vessels and pushing more follicles into and prolonging the active growth phase. It doesn't block DHT at all. It just gives existing follicles a stronger biological push to keep producing hair. The evidence is genuinely solid. In clinical trials, About 62% of men using 5% minoxidil showed visible regrowth in treated areas after 1 full year of consistent use. Plotted over time, results follow a predictable curve too, often an initial shed in the first few weeks as weak hairs are pushed out to make room for stronger ones, followed by gradually building visible regrowth from around month 4 onward. Finasteride works completely differently. It's a pill that blocks the enzyme converting testosterone into DHT in the first place, cutting off pattern loss's root hormonal driver rather than just stimulating follicles that remain. Put side by side, they genuinely complement rather than compete. Minoxidil stimulates any follicle regardless of cause, while finasteride specifically targets the DHT mechanism, which is exactly why dermatologists often prescribe both together for men with pattern loss. A newer addition worth defining clearly, PRP, or platelet-rich plasma, is a treatment using a concentrated portion of your own blood, rich in growth factors, injected into the scalp to stimulate dormant or weakened follicles. Grading the overall evidence honestly, minoxidil and finasteride both carry strong, decades-deep clinical trial support. PRP shows genuinely promising results but with a smaller, newer body of evidence worth trying, but not yet in the same evidence tier as the other two. One warning worth remembering with all three: none of them work overnight. Every one of these treatments needs a minimum of 3 to 6 months of consistent use before you can honestly judge whether it's working. Quitting at week 6 tells you nothing. So the real evidence-backed toolkit is small and specific. Minoxidil, finasteride, and increasingly PRP used consistently for months, not weeks. When medication alone isn't enough, hair transplant surgery enters the picture, and it works on a genuinely elegant piece of biology discovered decades ago, not just moving hair around cosmetically. That biology is called donor dominance. Follicles from the back and sides of the scalp are genetically resistant to DHT, and crucially, they keep that resistance even after being moved. Transplant them to a balding area, and they keep growing there permanently. 2 techniques dominate modern practice. FUT removes a thin strip of donor scalp, leaving 1 linear scar. FUE extracts individual follicles one at a time with a tiny punch tool, leaving no linear scar at all, which is why FUE now makes up roughly 3 in 4 procedures worldwide. Here's a real before and after showing what that actually looks like once fully grown in. The transformation isn't subtle, but it also isn't instant, which we'll get to in a moment. The hard numbers behind that photo are reassuring. Published data on FUE consistently shows a graft survival rate of 90 to 95% when performed by an experienced surgeon with proper graft handling. A real procedure day plays out like this. Local anesthesia numbs the donor and recipient areas, individual follicles are extracted one by one, tiny recipient channels are made in the balding zone, and each follicle is carefully placed by hand, typically taking 4 to 8 hours. Now for the timeline everyone underestimates. Transplanted hair actually sheds around 2 to 3 weeks in completely normal, before the follicle resets and starts producing real new growth around month 3 or 4, with final density visible only at 12 to 18 months. That timeline directly kills the biggest myth around the whole procedure: that you walk out with a full head of hair the same week. You don't, you walk out with follicles that need over a year to fully mature. So hair transplant surgery is real, evidence-backed, and permanent when done well, but it's a biological process measured in months and years, not a same-day cosmetic fix. Let's tie this together with a real kind of story. Arjun, 34, a software engineer, noticed a receding hairline in his late 20s, was diagnosed with early androgenetic alopecia, and started both minoxidil and finasteride immediately rather than waiting to see if it got worse first. His outcome captures the single most useful idea in this entire video. Hair loss treatment isn't about reversing years of damage after the fact. It's about protecting the follicles you still have while they're still salvageable. So use this as your own decision map. Early, mild thinning with active follicles still present favors medication first. Advanced, stable baldness with a healthy donor area favors considering transplant. And sudden or patchy loss always means see a doctor before doing anything else. Wade, honestly, medication and surgery aren't competitors, they're different tools for different stages, and they're often used together rather than as an either-or choice. Whatever your starting point, a few habits genuinely help across every cause we've covered. Manage stress where you can, eat enough protein and iron, be gentle with tight hairstyles and harsh chemical treatments, and don't wait months to get a real diagnosis. Step back and the overall evidence picture is genuinely reassuring. This is one of the most extensively studied, best understood areas of dermatology, with real, reproducible treatments for nearly every cause we've discussed today. So the entire video comes down to one honest sentence. Hair loss is common, mostly explainable, and, for nearly every cause we've covered, genuinely treatable as long as you start before you've waited too long. Here are the key references and sources for this video. Thanks so much for watching. If this helped, like the video and subscribe for more clear, simple explainers, and I'll see you in the next one.